Joining us today for Understanding the Affordable Care Act, or ACA, and SBIRT. I'm Tracy McPherson. I'll be your webinar facilitator today. If you have any questions about the webinar today, you're welcome to email me. And if there are any other issues or concerns or information that you're interested in about screening and brief intervention, you're also welcome to email me at the email address on your screen. Today's webinar is produced in partnership with NORC, the Big Initiative, the National SBIRT ATTC, NADAC, and SAMHSA. This webinar is part of our 2015 series. As you can see, we have a full lineup running through August. Many of these are already on demand and available for you to take advantage of at your leisure. We will be offering continuing education credits for all of these. We hope you'll take advantage of those. Those are free to you. And as you can see, we have some new topics in our lineup this year around adolescents and teens. And also a new topic for us is working within military culture. So I hope you'll take a look at our webinar series and download the flyer and share this with your friends and your colleagues and take advantage of all the free education we'll be able to provide you through this year. All of the materials for today's webinar are already up on the website. You can get a copy of the PowerPoint slides right now. The CE quiz will also be there following the webinar, as well as the on-demand live recording that will be available there as well. You'll also be able to access the CE quiz and earn your free CEs. And in addition to being on the website, you'll also get a follow-up email following the webinar within about 24 hours or so, which will have access to all the information as well. But you're welcome to go ahead and go to the website and download the PowerPoint slides now. And you can follow along that way, or you can follow along on your screen. Throughout the webinar, you'll be able to ask questions. We'll pause at the end and take those questions, but I would encourage you to get those questions in early. So please use the Ask Questions pane, the questions pane over on the upper right-hand side, and go ahead and get those questions in, and you can do it throughout the entire webinar. And behind the scene is our technical facilitator, Misty Story, with NADAC. She's the Director of Training and Professional Development at NADAC. And if you have any technical questions or other concerns, you can put those over in the chat box, and she'll be able to assist you with handling those. Our presenter today is Dr. Eric Goplerud, Senior Vice President of the Substance Abuse, Mental Health, and Criminal Justice Studies, which is now part of the Department of Public Health at NORC at the University of Chicago. Eric's email address is provided to you on your screen, so if you have additional questions following the webinar, you are certainly welcome to email him about those. Dr. Goplerud has more than 25 years in senior federal leadership and non-governmental experience directing numerous studies and task force on critical topics related to substance use and mental health integration in a range of healthcare settings, as well as experience developing curriculums and training for a range of health professionals. At SAMHSA, he directed the agency's Policy and Planning Office, developed and led the agency's Managed Care Initiative, and led the agency's Science to Service Initiative, and oversaw the agency's Finance and Quality Improvement Initiatives. As a research professor at George Washington University, he directed a major Pew Charitable Trust-funded project called Ensuring Solutions to Alcohol Problems, which was responsible for securing new SBI billing codes from AMA and CMS, increasing access to employer-sponsored substance use treatment, which led to an increase of 500,000 working persons getting treatment annually, and helped remove the UPPL law barriers to emergency department substance use screening in 17 states. At NORC, Dr. Goplerud currently leads with me 3 SBIRT Learning Collaboratives: the Adolescent SBIRT Learning Collaborative for Schools of Social Work and Nursing, the Brief Intervention Group, or Big Initiative Hospital SBIRT Initiative, and the big EAP and workplace SBIRT initiative. And the big learning collaboratives have developed common SBIRT curriculum and training for health professionals, for employee assistants and other workplace health professionals, addiction professionals, and a range of other medical and allied healthcare professionals. So I want to welcome Dr. Goplerud. Thank you so much for joining us today and doing this wonderful webinar. This has been a topic that I know many have been looking forward to, and we like to feature annually. So I'm going to turn it over to you.
Thank you, Tracy. The objectives, and I was feeling a little uncomfortable with all of the bio there because I was afraid that it was going to cut too far into our time together, because we've got quite a lot of ground to cover. We're going to spend some time to talk about access and coverage problems that the Accountable Care Act and what I'm throughout this presentation have called MAPIA, which just stands for the Mental Health Parity and Addiction Equity Act of 2008. So when you see those acronyms, ACA and MAPIA, what they really mean is National Health Reform and Parity. So the access and coverage issues that ACA and MAPIA were designed to address, the components of reform that impact access and coverage to screening, brief intervention, treatment, referral to specialty care, and follow-up for risky substance use and substance use disorders. Again, another acronym, SUDS, which you'll see throughout these PowerPoints. And then finally, some indicators of progress in integrating substance use screening and treatment into healthcare and the challenges still to be met. I have sort of a cheat sheet here, which I think probably you have as well, of a listing of the attendees. And I recognize a good number of names who have participated in learning collaboratives that we are running, Tracy, Misty, and I, people who have on-the-ground experience with trying to integrate care in this changing environment. So I really hope that while I'll be going through some statistics and perhaps sort of high-level discussion, that we have time at the end, and I think we have scheduled about a half hour, where I don't want that to be turned into just a question and answer if we can, but some discussion or type in over on the side what your experience has been and what have been some of the challenges and opportunities that you have seen. Because one thing that's very apparent is that the implementation of Parity and the Accountable Care Act is not uniform. It plays out differently in every location, in every state. And so making a presentation such as I'm doing today is kind of like taking the average temperature of the United States. It comes out with a number, but it doesn't tell you what the weather's like in Fargo or in Miami. And I really think the implementation of ACA and MAPIA are really that kind of local variation that people are experiencing right now. And same with the projections of what we expect to see over the next couple of years. Having said that, I'm still going to go through and sort of highlight some of the things that we've been seeing over the last couple of years in implementation. So one of the issues, and I'm going to be talking about the substance use risk and substance use services. Much of that also applies to mental health services and to other acute and chronic diseases, but we're going to focus on substance use risk and conditions, substance use disorders. So let's see if we can get this to work. Okay, over 90% of risky use and substance use dependence takes place between the ages of 12 and 20. And the dark maroon here is substance use disorder in the past year, and then the orange is risky use of alcohol or other drugs. What you can see is that it peaks right around 18 to 22, 24, something like that. And yet, if you take a look at the likelihood of coverage for substance use disorder, the likelihood of coverage increases as a person gets older. So clearly one of the big holes for prior to ACA and MAPIA is that the people who were at the greatest risk of having risky use or preventing risky or dependent use are the populations that were the most likely not to be covered by health insurance. One other really important finding to keep in mind is that persons with substance use disorders die an average of 22.5 years sooner than those without a diagnosis. Now, in this kind of a early death experience, average, is well known in mental health services. Public patients who are treated in the public sector in mental health die on average about 25 years younger than their peers. Well, people with substance use disorders also die substantially younger than their peers, and they die often from medical complications or medical illnesses that could have been identified if they were engaged in primary care or if they were engaged in treatment. So what we've identified, just to go back again, is that the population, well, I guess we're not going to go that way, the population who is most likely not to be covered, and this slide kind of shows this as well, are younger, they're poorer, and by not having access to primary care or to specialty substance use treatment, they're at risk of having disability and early death. So just some numbers, and I sort of apologize, but not completely. I've spent, I don't know, about 15 years, maybe 20 years as a college professor. So you're going to get numbers. According to SAMHSA and NIAAA, about 21.6 million Americans over age 12 have diagnosable substance use disorder, an average of about 8.2% of U.S. population. Also, prior to ACA, more than 47 million Americans lacked insurance. Of those, almost 15% of uninsured adults have a substance use disorder. So it's just under twice as likely that adults who did not have access to insurance or were uninsured had a substance use disorder. And not surprisingly, the treatment rate for people who were uninsured was pretty tiny. If you had a substance use disorder, you had about a 1 in 7, 1 in 8 chance of receiving treatment. And it gets even smaller if you don't include self-help, mutual support treatment or services in programs like AA, NA, Smart Recovery. 1/3 of those individuals who were covered by individual insurance had no substance use treatment coverage, and 5% at least in the small group insurance market had no substance use coverage. Finally, if we think about the way that ACA has been implemented, you had two populations. You had people who were who had over 138% of poverty, income over poverty, were eligible to go into the exchange, the health exchanges, and then you had the Medicaid expansion populations, or people who would be eligible for the Medicaid expansion. Uninsured had rates of substance use of about 14% in both groups, a little bit less for the Medicaid expansion population, a little bit more for those going into the health exchange. But this is higher rates than the average for Medicaid recipients. This is primarily because those individuals who were eligible to go into the Medicaid expansion or the exchanges were more likely to be young males and poor, who typically were not in the Medicaid recipients prior to ACA. Again, much variation between states. Now, these are the rates prior to ACA and Parity of substance use disorders. What you can see is in every one of these instances, for 12 to 17-year-olds, for 18 to 25s, and 26 and older, that the prevalence is high, the prevalence of the condition is high. The rates of treatment are extremely low. Not a surprise to anyone who's probably on this call, but some numbers. What we found, and this you could find these kinds of descriptions. This is in general the percent of men and women who say that they or a family member have done each of the following in the last year because of the cost. There are very similar kinds of charts that can be created and have been created out of the National Survey on Drug Use and Health. This is the general population, and you can see that men, and especially women, were more likely to put off care that they needed, skipped a recommended medical test or treatment, did not fill a prescription, cut pills or skipped doses of medications, and had problems getting mental health or substance use care. So what was Parity and ACA about? These are primarily coverage and access laws. Quality sometimes enters in, but it's not the primary function of these two laws. It is to provide better health insurance coverage or better coverage of health insurance for mental and substance use disorders and improving access to care. It's very important that we judge the outcomes of these laws on what were the issues that they were trying to correct. And the outcomes that ACA and the PIA were primarily designed to correct is the low levels of coverage and the low levels of access to care, low levels relative to medical care for non-mental health or substance use conditions, and then also low access to any kind of care because of lack of insurance or insurance coverage. Now, why after 100 years of lack of access to care, low insurance rates, did we finally get the passage of MPIA and ACA? Well, there's sort of a vicious circle that keeps making the system, it's a downward spiral. Consumers can't afford a doctor, so the consumers delay care and end up requiring catastrophic or emergency services. Consumers can't pay for those emergency services. Providers, particularly hospitals, shift costs to those people who are insured and to their insurers. The insurers shift costs back to the consumers through higher deductibles or very high deductible health plans, through co-insurance or co-payments, and the consumers drop their policy due to high price and they're now uninsured, and the cycle gets worse. So primarily in this cycle, it is a payment cycle, a coverage cycle that ACA particularly is designed to address. Now, as complicated as ACA and MAPIA are. It actually comes down to a fairly simple tripod, which, if it were working correctly, and it is in some states, almost everyone would be covered. It would be covered through people who receive their health insurance through their employer or their workplace, through expansion of Medicaid for people who are poor, and through federal or state health insurance marketplaces. Altogether, they should cover almost everyone in the country. There are exceptions. Undocumented immigrants would not be covered. There are some other small populations. And the next slide shows you where particularly Parity covers and doesn't cover, and many of these populations also are not included. Those that aren't included in MAPIA are also not included in ACA. So this kind of goes through what are the various categories that are now included, and where the law saying that if you're covering mental health or substance use services, that they have to be equitable with medical and surgical. So ERISA-governed self-insured plans, these are the plans that are offered generally by mid to large-sized businesses, are covered, are required to have parity coverage by MAPIA and also by MAPIA. Also, ERISA-governed fully insured plans. Those are, for example, your likely Blue Cross Blue Shield plans, Aetna, Cigna, United Healthcare, that are offered as group plans and are regulated typically by state insurance commissioners. They're called fully insured plans, and yes, those are covered by ACA, by MAPIA, except that there are certain size and cost exemptions. Employers below 51 employees are not required by MAPIA to have parity coverage, and there's a fairly complicated process of if the increased cost of covering mental health and substance use is more than a couple of percent. I think it's 3%, but I could be off. It may be 2%. A company can request not to be covered for 1 year. It's complicated. Basically, it was made to be so complicated that employers would just go ahead and have full coverage. The next category is the state-regulated group and individual insurance markets, and the interpretation of ACA, the Accountable Care Act, was that parity extended to the group and individual markets. So the health insurance exchanges now are have to offer parity coverage as an essential benefit. Medicaid fee-for-service is not required to be at parity. Medicaid managed care, however, in a notice I live in the acronym world, NPRM, notice of proposed rule making from CMS, is that CMS Medicaid is moving towards requiring parity coverage for any patient who is in Medicaid managed care, which is about 70% of all Medicaid patients, both the expansion patients and the regular patients who are already in. Separately administered children's health insurance plans, yes, are covered by parity. Medicare fee-for-service is not, nor is Medicare Advantage. So Medicare is not covered. The Federal Employees Health Benefits Program is not required, but if the program has adopted MPIA. TRICARE does not, and it has much more restricted benefits than Parity would require. Church plans are not required. Churches are exempt. And non-federal public employee plans are covered by Parity, but state and local government, public schools can opt out of Parity. Very, very small numbers are, but they are exempt from Parity. So this just summarizes again. Large self-insured and group health plans are covered. Medicare Part B, which is the outpatient benefit, has co-insurance parity with medical surgical. So where for a primary care visit, you pay 20% of the cost of services, and Medicare picks up the other 80%. It's the same now since 2014 for mental health and substance use services, ambulatory only. Essential health benefit, one of the required essential health benefits is mental health and substance use treatment. A second one is preventive services. Medicaid benchmark benefit must be at parity. Parity extends to all individual and most small group plans in the insurance exchanges, and Medicaid MCOs, rather than, I misspoke here, it says must be at parity. In fact, the proposed rule, if it is adopted, would require parity, and that will be sometime in probably 2016 that would happen. This is a listing of the mandatory essential benefits that health insurance delivered through the health exchanges, either the state exchanges or the federally sponsored exchanges. And what you can see highlighted here is that mental health and substance use disorder services are one of the required 10 benefits, as well as preventive and wellness services. When Frank Baronio and Gleed estimated the proportion or the number of people who will be getting new coverage under ACA, these are the numbers. The total number of people who will receive new coverage for mental health and substance use care is 31 million people. For expanded mental health and substance use care from what they had before was 30 million. And all total, across the country, more than 62 million Americans will have coverage at parity for mental and substance use treatment. The estimates indicate that there will be about 2.8 million adults who will receive behavioral health treatment through Medicaid expansions annually, and 3.1 million who will receive mental health and or substance use treatment through their participation in health insurance exchanges. So what we're looking at is an increase of about 6 million people who are able each year to access mental health or substance use care. Now the majority of that is going to be mental health services or for treatment of mental illnesses. The comorbidities of substance use are substantial in that population, as well persons who just have a substance use disorder excuse me, will receive care. The ACA requires private health plans to cover preventive services, and that covers basically all of these groups, and it applies to plans that are available in the marketplaces because preventive services are an essential benefit. This is a fairly detailed listing, and I've been told that all of these slides are available, as Tracy said at the beginning. All these slides are available, so you can look at any of these slides in detail when we finish the presentation. But I just wanted to point out here with the arrows is that alcohol misuse screening and counseling for adults, depression screening and brief counseling, and tobacco screening and cessation interventions. And then additional where there are substantial comorbidities, interpersonal and domestic violence screening and counseling. All of these are preventive services that are covered without cost sharing, meaning that the entire cost of the preventive service will be paid by the health insurer, by Medicaid or Medicare. And I'm not sure whether I misspoke there about Medicaid. But anyway, I know for sure for Medicare and for commercial insurance, the patient will pay nothing for the preventive services. The aim is to encourage people to come in and get preventive services for these to be, remember, this is to improve access to care and earlier care. The health exchanges, which we hear about a lot during the open seasons, there are really three types, but they all basically do the same thing. We'll find out when the Supreme Court makes its decision as to whether federally facilitated exchanges and state partnership exchanges will continue to operate and be able to give people subsidies. But currently there are federally facilitated exchanges. That's the ones that had such computer problems last a year ago, winter into spring. State partnerships, which are joint between the feds and the states, and state-operated exchanges. Second enrollment period mostly ended. However, there were extensions for a limited number of people. I believe that has now ended. The scope is for uninsured adults above 133% of federal poverty level, plus there's a discounted rate. So basically it is for adults who have an income of 138% of poverty or above. There are premium subsidies of for the cost of health insurance bought through the exchanges of up to 400% of poverty level. In the Medicaid expansion states, that's it's 133% of poverty plus that 5%, so 138% of poverty up to 400%. For those who are in non-expansion states, it's 100% of poverty up to 400 are eligible for subsidies. Oops. Well, let's see if I make this one go back real quickly. Here we go. This just briefly shows what the premium is as a percentage of income and the amount of subsidy support and cost sharing. This is just a detail, I threw it in. We've heard about the 4 different types of plans that are all by metal. The benchmark plan is the silver plan, which pays 70% of covered medical expenses. One of the concerns about the silver plans is that many of them are that are offered in the state and federal health insurance exchanges are high deductible health plans where an individual or family may be paying $2,000, $4,000, $5,000 out of pocket before their insurance starts to cover. The problem we have seen in early high deductible health plans, we have not seen them because there hasn't been enough time yet. But what we saw in previous to ACA high deductible health plans is that people with mental health and especially with substance use conditions tend not to use the mental health or substance use services because they have to put the money out of pocket so much before they get up to the deductible. And early evidence was suggesting that mental health and substance use were being considered, especially on an ambulatory basis, as discretionary health care. You've probably heard a bit about the individual mandate. The individual mandate requires that all citizens and legal residents, with some exceptions, have health coverage by 2014. What happens if someone does not meet the deadline? Do they go to jail? Absolutely not. They get fined, I think it was $65, a fairly small amount of money through IRS an IRS adjustment to income tax. There are quite a few exceptions: religious objections, undocumented immigrants, people who are incarcerated, American Indians and Alaska Natives, people with income below a tax filing threshold, or if the lowest cost plan exceeds 9.5% of an individual's income, they would not be subjected to the individual mandate. Medicaid expansion. The light green are the states that have expanded, and the darker green are those states, and the estimates from the American Mental Health Counselors Association estimates of the number of people who have mental health or substance use, yes, the number of uninsured adults with serious mental health and substance use conditions who are eligible for coverage in the 25 non-Medicaid expansion states. So you can see, for example, the estimates are in Texas that 652,000 people with mental illnesses and or substance use disorders would be eligible for the Medicaid expansion were the states to so choose. So again, the point is that ACA and the PIA were designed to be coverage and access laws, and we can see what the consequences are for that not having full coverage. So this is a picture of the way that in a Medicaid expansion state that health insurance coverage should work and is pretty much working. Market subsidies up to 400% of poverty, from 133% to 400%. Medicaid covers a substantial part of children. Medicaid expansion covers those persons below 133% of poverty, covering these groups down at the bottom: jobless parents, working parents, pregnant women, other adults who were low income. Above 400% of poverty is where employer health insurance and the individual insurance mandate would cover the rest of the population. In the non-Medicaid expansion states, you can see in white the populations that are not covered. So pregnant women are covered by Medicaid and CHIP, some working parents, and a small percentage of jobless parents, but other adults, especially males who are poor, are not covered by either the marketplace subsidies or by Medicaid and CHIP. Vary substantially by state, but we see the whole. Also with ACA is we got new financing models of care, and I'll highlight just a couple of them. Medical homes or patient-centered medical homes, patient-centered health homes have four characteristics. They're centered, or they value primary care. Care is patient-centered rather than illness or episode or visit focused. Advances in chronic care are promoted, so case management, outreach, patient education, patient activation, and use of health information technology. ACA expands the medical home concept through pilot programs, through the creation of state Medicaid health plan options where the states can permit Medicaid beneficiaries with chronic conditions and so serious mental health conditions to designate a provider as a home. Another innovation with ACA is the Accountable Care Organization, or another acronym, ACOs. Accountable care organizations have many of the same characteristics as medical homes. But in this case, there is a population-based responsibility. The provider-based organization, which very often is based around a hospital or a number of hospitals and primary care practices and often specialty care practices. The provider-based organization takes responsibility for the healthcare needs of a defined population, often in groups of 5,000 or more individuals. The goal is to improve health, improve efficiency of care, and improve patient satisfaction. These are generally associations and financially, in some ways, integrated care delivery systems that include hospitals, primary care, and specialists that can include substance use disorder and behavioral health conditions. And the Accountable Care Organization is designed to share the savings and other financial incentives from the payer for caring for an entire population. So not only the entire individual's care across the lifetime, but a population. And if we're still in the very early stages to find out how that's working. So what's happening and what's projected to happen around parity, coverage, and location of care. The implications, there are at least 4 highlighted areas. We can expect that substance use treatments are much more likely to be delivered through primary care settings, and the reimbursement for care, for treatment, will be similar to other acute and chronic diseases needing long-term management. This is very much different. It's a shift that we're seeing throughout the country from specialty care to much more emphasis on primary care. We'll get into that a little bit when I discuss hotspots. Secondly, there is an emphasis on prevention of high-risk alcohol use. Evidence is still out about prevention of drug use. Preventive services for alcohol use are a covered benefit, and we see more and more routine screening for substance use and related problems, brief intervention, and referral to treatment, or the tricky acronym SBIRT. There is the allowing individuals with a pre-existing condition to have insurance coverage, so individuals with substance use disorders or mental illness cannot be excluded, and we expect that individuals who have received substance use treatment in the public sector are going to be moving to receiving substance use care in the mainstream healthcare system. And through the expansion of Medicaid, we expect, as those numbers I shared earlier, that we will be seeing somewhere around 3 million new people per year who have a mental health or substance use condition, or people who receive mental health or substance use services or treatments through Medicaid, and about another 3 million will receive it through the health insurance exchanges. And substance use treatments, including medications, will be covered by Medicaid and by, we expect, also other insurers. Let's see if we can get, there it is, okay. Now, SAMHSA has developed projections of expenditures for treatment of mental and substance use disorders and projected them out to 2020. The well, I don't know what color that is, sort of gold line, is what the estimated annual growth of spending is for mental health. And you can see that about up until about 2012, pretty consistently, the rates of expenditure, of increased expenditure for medical conditions was substantially higher than the average for substance use treatment. It's just for substance use treatment. In 2012, 2013, they begin to track pretty closely, but we can still see that there is projected to be a gap where substance use treatment is projected not to increase at the same rates as the spending for other medical conditions. Probably a variety of reasons. One important one would be that medications are not as prevalently used as with other medical conditions, but also is probably residual discrimination. Medicaid is projected to become a larger share of substance use treatment spending as Medicaid eligibility expands. And here the blue, as you can see, the quick jump up there in 2009 and continued expansion up to 2020, where it's estimated that 28% of the cost of substance use treatment will be borne by Medicaid. Private insurance, as you can see, actually has dropped and remained fairly stable, and there still is a pretty substantial component of federal, about 10%, and state and local government support for substance use treatment. And remember, we're also should be seeing through access, improved access, that the location of care should be changing so that we're getting less residential, acute, emergency department, hospitalization of care, and much more of it shifting into ambulatory. At least that's what you would expect. According to SAMHSA and their estimates, is that still specialty substance use centers, this is that sort of bronzish color here, will contribute about 31%, nearly a third of the increase that is going to go, expected to go for substance use treatment, will go to specialty substance use treatment centers, and 28% will be going to, of the increase, will be attributed to hospitals. This part, the maroon part, 25% will be an expansion in office-based professionals, and that is office-based mental health and substance use professionals, community behavioral health centers and programs, specialty substance use programs, primary care. I'm sorry, not specialty substance use programs over here, I'm sorry, is 31%. Retail pharmaceuticals are expected to contribute a fairly small percentage. Now, what is the effect of parity? A very interesting study came out a couple of years ago that looked at what happened to the proportion of the percent of the healthcare dollar that went to substance use treatment in states that had passed parity prior to the MAPIA and states that had not passed parity. That upper chart shows, and that what they did was standardize it so that 0 is the point at which parity was passed, or by comparison, other states that did not change their laws. What you can see is a very tiny increase in the percentage of substance use treatment. Tiny, maybe 0.2%. And the lower chart shows, breaks out much fuller. The dark dotted line on the top is the percentage of substance use treatment that for states that went from partial parity to full parity, which is what we would say MAPIA put through, we got an increase of about 2 to 0.3%. In those states that went from no to full parity, we can see that the increase was, what's that, about 0.4%? And in those where there was no change in parity, there was virtually no change in access. So yes, there was a gap, but the gap is not very large. So one of the things that this suggests, that passage of the law is insufficient in itself to increase access to care. It probably requires advocacy and some other things. Now, foreshadowing what was going to happen with MAPIA and ACA's extension of parity to virtually all insurance coverage was the Federal Employees Health Benefits evaluations. The Federal Employees Health Benefits went to full parity, I think that was in 2001, and the HHS funded a very careful evaluation of the impact of parity and compared it to health plans that did not have federal employees in them and were not subject to the parity requirements. What the evaluation found, in the citations there on the bottom, there was no difference in the rate of access to substance use treatment between the parity plans, the FEHBP plans, and the non-matched federal employee health benefits plan, other plans. So comparing, for example, Blue Cross Blue Shield, which was the major payer of care for federal employees, matched to Blue Cross Blue Shield plans serving a general employed population. There was no difference in the rate of access. For patients who did receive substance use treatment, the out-of-pocket spending declined significantly relative to federal employees' health benefits. It declined by about $100. Total spending on substance use treatment did not differ between the two types of plans. 10% more patients were identified with a new substance use disorder, but there were no differences in the initiation or engaging patients in substance use treatment between the two types of plans. The conclusion, and this is a quote from the Ozone article, parity improves insurance protection, but has little impact on utilization, cost to plans, or quality of care. Again, what ACA and parity has been about so far is coverage and access. Now, do the health insurance plans in exchanges comply with parity? This is a question that has just been reported out in psychiatric services. I think this may still be in press. Looking at two states and the insurance that was offered in the exchanges, one a large state and one a small state, 75% had quantitative treatment limits and prior authorization requirements that were equivalent to medical surgical benefits. So on paper, at least, about 75% of the insurance plans offered appeared to comply with parity requirements. In the smaller exchanges, in the small exchange, about half of the plans, though, were required prior authorization that was more restrictive than for substance use and mental health than for medical surgical. In the larger exchange, they were more likely to encounter inconsistent financial requirements. So, for example, co-pays or co-insurance or deductibles were higher for mental health and substance use than they were for medical surgical. And the requirements for substance use were found to be higher than for mental health, or inappropriately matching, so that they said a behavioral health treatment should be matched to a surgical or a specialist, medical specialist, rather than to a primary care. So there would be a higher rate of copay. The importance of this slide and the importance of this issue is that what happens on the health insurance exchanges is something subject to state insurance commissioners and to federal regulators. And if they are not paying attention, if advocates are not demanding that they pay attention to parity, it's likely that there will be instances, and maybe many instances, where benefits actually are not at parity, either on paper or certainly in their actuality, how they actually are carried out. A study that was just completed in 2014 looked at the readiness of specialty substance use treatment programs for working in an insurance, health insurance, fee-for-service, ACO, medical care environment. This is done by the folks at NIATEX. And what they had 427 substance use organizations that participated over the course of 2010 to 2012. Most, they found, were in the early stages of preparation to be prepared to live in this new insurance-based environments. Organizations that had annual budgets greater than $5 million were more likely to be prepared than those that had smaller budgets. So while many of the, if we look at the specialty substance use treatment system, the majority, the large majority of them, of our programs are have budgets of less than $5 million. And what this analysis indicated is that they were slow at getting prepared to live in this new environment of expanded coverage, potentially expanded access, paid for through insurance, health insurance. Now, quickly, some hotspots for SBIRT and improving access to care. And places where we're seeing SBIRT, we're seeing substance use screening, brief intervention, treatment, and referral to treatment taking place. And these are in the medical side, hospitals being the first one. A Cochrane collaboration review found 14 randomized controlled trials, or RCTs, covering adults and adolescents for opportunistically identified medically ill or injured patients who received a screening and brief counseling while they were inpatients. The outcomes favored brief intervention over non-treatment control patients. And the findings that were consistent were a drop in alcohol consumption at 6 months, at 9 months, and at self-report at 1 year, and significantly fewer deaths at 6 months and a year. So these are patients who are hospitalized for medical conditions or for injuries who receive a screening and brief intervention. And we find consistent, the research shows consistent positive effects. This is one of our leaders and mentors of many of us in emergency department screening and brief intervention, Ed Bernstein, in a wonderful video clip, which I'm not going to play, but a systematic review of emergency department randomized control trials with pre and post brief intervention results. 11 out of the 12 observed significant effects on alcohol intake, risky drinking practices, alcohol-related negative consequences, and injury frequency. Again, I'm stressing alcohol here. The evidence is much more inconsistent or negative of the effect of SBI in emergency departments for patients with illicit drug or prescription opioid misuse or dependence. But what we're finding is that hospitals all across the country, and here are just a few of them, have, through their own resources or in partnerships with substance use treatment programs, have formed partnerships where they are providing screening and brief interventions in their emergency departments and in their hospital settings. What I particularly wanted to emphasize is that, let's see, it must be 2/3 of these, the programs were started without grant funds. So these are not SBIRT state grantees. These are programs that saw a medical need for improving rates of identification and treatment, rather than responding to, say, new resources coming in from a grant. Gunderson Lutheran program in Wisconsin, which did participate in an Wisconsin State SBIRT grant with Rich Brown, found positive outcomes for patients who were followed up immediately and at a longer period of time. But one of the things that, let's see if I've got that here. Yes. Gunderson built screening and brief intervention into their electronic health record. So there were prompts and there were screens which showed how you walk through and code for substance use screening and brief intervention. It became part of the medical record. It became part of nursing procedures. A similar really terrific example is at Oregon Health Sciences University, where if you go out to this website, sbirtoregon.org, you can see how they walk through, the clinician is able to walk through an electronic health record and chart both the SBIRT service provided, but it also populates the billing record for Medicaid, Medicare, commercial health insurance. But they did the same thing. They moved it into the electronic health record, and SBIRT became a profit center rather than a cost. Now, you can get paid. These are the rates for emergency department SBIRT reimbursement. This is now, I think, about 2 years old, and I got this from a hospital in Colorado. Substantial variations from state to state and from payer to payer, but in the emergency department, yes, you can get paid. Now, I heard something rather pernicious in Kansas recently that some hospitals with some insurers, if in the emergency department they screen for substance use and submit one of these claims, that the insurance companies are denying payment for the entire care of service delivery, which is one of the most, a really terrible use of screening and brief intervention to deny care. A second concern, or a second hotspot, where screening and brief intervention helps the medical care, medical system deliver better care and get better outcomes, is prenatal screening and case management. A terrific program developed in Kaiser Permanente, Northern California, called Early Start, has universal screening of all pregnant women in their first prenatal visit, screening questionnaire, and with consent, a urine tox. A mental health provider, a social worker, is attached and inside of the OBGYN department so that patients who are pregnant and who screen positive for alcohol are receive counseling services, brief interventions that are associated with their prenatal care. So there isn't any kind of a barrier. It takes place in the same office at the same time, the same appointment, and there's no additional billing for the social work brief intervention. Plus there's education for all women and providers. The outcomes are significant and immediate. For those patients who receive screening, SAF is screening, assessment, and follow-up, and SA is screening and assessment, the rates of stillborns or intrauterine fetal demise were 14 times less than those patients who screened positive but did not go for, did not receive, this was at their choice or for whatever, did not receive a brief intervention. Controls for those patients who did not have a substance use or an alcohol use. 14 times greater rates of stillborns for those patients who did not receive the brief screening and brief intervention. The costs were substantially less. So these are those who screened positive but did not receive the brief intervention. Their costs are substantially higher because both the maternal costs, the mother's cost, and less neonatal intensive care unit costs, overall costs were substantially higher for those who just received the screening. And you can see that it actually was a non-significant difference between controls costs of the pregnancy and delivery as for those who screened positive. Third place, hotspot, ambulatory primary care, SBIRT. And a shameless plug here to the brief intervention group, or the big initiative, which Tracy mentioned, and huge amounts of material available on the big initiative. Tracy and I recently completed an analysis of SBIRT integration into primary care, and we used a framework called the Consolidated Framework for Implementation Research, which said that barriers or facilitators for integrating any new service in a healthcare system is going to be a combination of the characteristics of the intervention itself, so SBIRT in this case, the process of implementation, how it's done, the inner setting, the characteristics of the providers, how they're organized in teams, their electronic health records, how they communicate with one another, and the individual and team characteristics. And these were the preliminary findings, I think. Let's see if I've got them here. Here we go. Okay. For intervention characteristics, support for SBIRT in primary care must come from credible leaders, which may not be SAMHSA. It may be HRSA or the family practitioners, family physicians associations. There's a need for a standardized brief behavioral health screener that includes alcohol, drugs, tobacco, depression, anxiety, very, very quick. And the ability to adapt substance use risk assessment and intervention so that it works within the workflow of the setting. In the outer setting, there's a need to standardize screening and brief intervention as a routine part and a standardized part of electronic health records. Screening and brief intervention has to be viewed as an essential element of patient-centered primary care. Removing provider communication restrictions, and one of the provider communication restrictions that we see coming up over and over again is the federal privacy, substance use privacy regulations known as 42 CFR Part 2, which often act as a barrier of communication between specialty substance use care and primary care. Removing reimbursement barriers, many of which are knocking down because of parity. Accountability of primary care to payers so that they're delivering the services, and integrating substance use services throughout all of the primary care behavioral health integration efforts. So when we talk about primary care behavioral health, you can't imagine not including substance use along with mental health as part of integration. The inner setting of what facilitates or acts as a barrier to integration of SBIRT in primary care are what facilitates is organizational development consultation of integrating substance use screening and care management as part of the routine practice. It fits within the workflow, the speed of service delivery, patients coming in rapidly into a primary care setting. Competency-based training of behavioral health clinicians in substance use. So the specific skills needed to provide the screening and brief intervention, and integrating the substance use records into electronic health records, facilitate the uptake and the maintenance of substance use SBIRT in primary care. The characteristics of individuals that facilitate is the provision of continuing education for primary care and behavioral health personnel, substance use training as part of the pre-professional workforce development, something that Tracy McPherson and I are very much involved with, is the development of training materials that can help nursing and social work students and schools of nursing and social work to infuse substance use screening and treatment education into their baccalaureate and their advanced practice programs. And then recognizing community health centers that are in primary care practices that are doing outstanding substance use care so that others can emulate them. And then finally, around implementation, what facilitates? We found that there is a terrific model of facilitating the integration of substance use screening and brief intervention, and that's in the VA system, where they have a substance use disorder quality enhancement center that works with the individual sites and works across the VA system to integrate screening and brief intervention into the electronic health record, into performance metrics, and into clinical practice. This slide I've been showing for about 5 years, and this is that you can, in fact, get paid to deliver screening and brief intervention in primary care. And what's, I think, particularly important, and this comes from a report from North Carolina, is the benefits that providers, primary care providers, report. You know, they report that people come back. They may not be ready for getting help today, but they will in the future because of the relationships developed by the behavioral health screener. Or screening is a lot like prevention. You do screening to prevent things upsetting or complications. I think we should be involved in screening. Probably some of the most powerful reasons given for integrating are those that are given by providers and by their patients. Patients expect doctors are going to be asking them difficult things, and the gratitude the patients express when getting help is what keeps an awful lot of us going. Outlook for MAPIA, transforming substance use care, we can expect that over time, substance use screening and treatment will be more widely dispersed through a variety of settings. There's going to be less of the standalone or separate substance use treatment programs where applicable to the federal 42 CFR Part 2, trending towards more integrated care systems through medical homes, ACOs, health homes, and the general healthcare industry being used to exchange health information freely, including substance use, diagnosis, and treatment. There are hotspots where we will see early adopters of SBIRT, and some of those 8 or so hospitals that I identified are some. Any healthcare facility can run a successful SBIRT program with the right preparation and ongoing dedication. Electronic health record integration can secure billing efficiency. You can make money from screening and brief intervention. And finally, the passage of laws does not immediately result in improved access or improved quality or reduced costs. That vigilance, advocacy, and planning are needed to realize the potential transformations that can come from ACA and MAPIA, but are not guaranteed by just having the laws passed. So just a couple of phrases. Heraclitus, one of the first of the pre-Socratic philosophers, said nothing is permanent but change. And from Charles Darwin, it is not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. So I want to thank you. I'm going to quickly zip through a couple of things for you to see so that if any of you want to know where I got these citations or got these, there are access information for a lot of these materials that are posted at this hospitalsbirt.webs.com that's here. And you'll see here many citations and more citations and more citations. I think that's all of the citations. As you can see, a lot that's going on, a lot of potential, but with absolutely no guarantees. So at this point, I think I turn this over or jointly between Tracy and I so that if you have any questions, we can address them, or if you'd have any comments, we can share them over the next 15 minutes or so. Tracy?
Yeah, thank you, Eric, and thanks for sharing a lot of very rich information and data and talking about some of the hot spots of activity. I think that's where we're seeing a lot of innovation and where the barriers of facilitators you were talking about have been navigated, and a lot of lessons that have been learned from their experiences and gleaned in some of the recommendations that you made. And so thank you for sharing some of those as well. I'm going to look at the questions that we have coming in, but I also want to remind folks that there is a questions pane over to the right side in your panel where you can go ahead and type your questions in there. We'll get to as many of those as we can. We have about just shy of, I think, 10 minutes or so to address some questions. So let me, some of them are a combination of comments and questions. So, and some are a little bit long. So Eric, if you need me to repeat any of them, just let me know.
And I'd be happy to answer some questions afterwards. If we don't get to all of them, I can answer them and we can post them up on the website.
Oh, great. That's terrific. Thank you. So the first one, according to the essential health benefit rules covering adolescents, evidence-informed preventive care and screenings provided for in guidelines supported by HRSA are required to be covered. My reading is that since adolescent alcohol and drug screening and assessment, quote, unquote, alcohol and drug screening and assessment is included in these guidelines, that private payers are required to cover the S part of SBIRT, so the screening part. Is that the case?
I don't know. I guess the other part about responding is if I don't know the answer, I'll go look it up and I'll post it.
That sounds good. And this one is particularly focused on adolescents, so I think and there may be some differences there between adolescents and adult populations. But I often get a similar question when I'm out on the road and training on how to do screening brief intervention. Is it really only the S part of SBIRT that gets paid for? Is the brief intervention piece included in that when you're talking about coverage under an essential health benefit? There seems to be maybe it's just common thinking when that it is only the S. So it's interesting this question because it seems to be coming up a lot when I'm out there on the road.
Yeah, it's just the problem with adolescent screening and brief intervention is that the MAPIA, or I'm sorry, the ACA requires that insurers cover preventive services that have received an A or B recommendation from the U.S. Preventive Services Task Force. The Preventive Services Task Force does extensive reviews of the research literature and makes recommendations. The task force has recommended that alcohol screening and brief interventions for adults receives a B level and so is covered. However, they have not felt that the research is sufficiently strong. It's not that it's ineffective, but the research is not strong enough for them to make a statement about whether adolescents and persons with illicit drug or prescription opioids should receive a brief intervention. The research is not strong enough or sufficient. So therefore, I would think that ACA would not require coverage of adolescent screening for risky alcohol use. But as I said, I could be wrong on that, and I'll look that up and I'll provide a note.
That's great. Thank you. Second question that's come in is regarding preventative services being paid by insurance entities. Does it matter if the preventative service occurs in an emergency department? So I think we're sort of getting at, does it matter whether it varies between setting and setting? Hospital, we talked about hospital and primary care and emergency departments. Does it being paid by insurance entities matter? And does it vary for particularly, in this particular case, an emergency department?
I wish I could say that there's a uniform answer, but I have seen where the same payer will pay an emergency department. If you go back to the slides, or the slide of an emergency department screening brief intervention for alcohol and drugs, the same payer will pay $165 for some screens, others for some patients. Others they will pay $85. Others they will pay $35. Others they will pay nothing. Same insurer, same hospital. There is incredible inconsistency, and because SBIRT, or the screening brief intervention services, are comparatively low dollar amounts, I think many emergency departments are not as vigilant as they could be on whether they're getting paid for the screening brief intervention service. Now, we do have a number of hospitals that are using the screening and brief intervention in the emergency department to, on their insurance bills, they increase what's called the complexity of the service provided, because they're also doing the preventive service as well as stitching up your cut. They can charge at a higher rate. It's called upcoding. And so a number of hospitals are doing screening and brief interventions as part of the medical service provided in the emergency department, and then it gets coded as a facility code at a higher rate for the bundled service. Yeah, again, it unfortunately varies substantially. And then we have the instance of Kansas where they're using the screening and brief, some insurers are using the screening and brief intervention as a trigger for denying coverage for for all of the medical care provided in that episode of care. A really pernicious activity.
Thank you.
So again, I guess the answer is it depends.
Right. All right, thank you. The next question we have, you talked a little bit about substance use disorder treatment in primary care settings. Mm-hmm. And what type of provider, who would it be in a primary care setting that would be likely, either now or what we think will be in the future, to be providing substance use disorder treatment in that setting, if we might see it happening there more and more?
That question is what we call a fastball being pitched right down the center. Let me take a swing at that one. I think that what we will be seeing is that primary care clinicians will become more comfortable at managing substance use disorders as they are in treating the wide variety of other medical conditions that come into primary care. They are not, and probably will very rarely be, specialists in substance use care, but a very, very important part of screening, brief intervention, and if you've heard, I've been saying screening, brief intervention, treatment, and referral to treatment, is the prescribing of medications, which will, I think, become far more common for the treatment of addiction. And that can be done and managed well in primary care. We're seeing a model which is extremely exciting that's called the Integrated Behavioral Health Clinician, or IBHC. One of the most interesting developments I've seen in years and years, where just as primary care clinicians are specialist generalists, meaning that they specialize in managing a vast variety of functional and medical problems, we're seeing behavioral health clinicians that are embedded and are also specialist generalist behavioralists, meaning that they specialize in being able to manage a wide variety of behavioral conditions that are coming into the primary care setting, working in the same kind of speed, in the same practice style as the primary care system. So they are not scheduling 50-minute interviews. They are not anticipating that they're going to have an office where they put their pictures out and memorabilia, but rather are going to be walking into examining rooms, are going to be pulled into hallway conversations with primary care nurses and doctors about managing depression. And then the next patient, it's a brief intervention on alcohol, and the next patient, it's going to be an eating disorder, and the next patient's going to be perhaps cognitive disorder, possible Alzheimer's, and the next one's going to be diabetes. So what we're seeing really exciting is these integrated behavioral health clinicians who are operating and functioning as part of the primary care team. And then backing them up may be specialists, specialized substance use or mental health or oncologists or obstetricians or any of the other specialists that we have. But this IBHC, I think, is an incredibly exciting model where behavioral health clinicians are operating within and as part of the primary care team.
All right, thank you. Thank you. And we have seen that in some of the site visits we've been doing across the country and the interviews, and so thanks for sharing that.
Oh, and let me jump one other. Some really exciting work, which some of you may have already heard me talk about, is where specialty substance use treatment programs are contracting with community health centers, where the community health centers are contracting with the substance use treatment program to deliver substance use screening and treatment inside the community health center, or where hospitals are contracting with specialty substance use care to provide counselors in the emergency departments to manage patients coming in with overdose or in withdrawal or at risk of withdrawal, so that the specialty care is providing services into the medical care system and operating within the system. We've even heard of a very innovative program in Massachusetts that has contracts with OBGYN practices to deliver the screening brief intervention services that I was describing for prenatal care. So it isn't that substance use specialists and specialty care goes away. It is there are new opportunities to deliver care within a healthcare system that is being paid through these improved access and improved coverage that we see with ACA and the PIA.
Great. Thank you, Eric. Appreciate you expanding on that. And unfortunately, it's such a topic that everybody has been really looking forward to, and we could have discussions, and I see a few more questions have come in, but what we're going to ask you to do is we'll share those questions with you, and if you're able to respond to a few of those, we could put those together and make those available. I know there are some specific kinds of things as well as some questions on some codes. We'll get those to you. So I just want to summarize and just in our last few minutes thank everyone for joining us today and pointing out that the PowerPoints again are on the website on a page dedicated at this URL to this particular website. You'll find the PowerPoint slides, access to the CE quiz, the on-demand recording, as well as how to take the CE quiz, get the CEs. In fact, Misty Story has already put over in your chat box a link to these materials. Also, I wanted to ask everyone, it's really critical that we get your feedback and get an evaluation. It's a very brief, short survey. You'll see over in your chat box a quick SurveyMonkey link. It really is critical to our project to get your feedback. If you could complete that brief evaluation form, we'd be really grateful. You'll also receive a follow-up email from Misty Story with all these materials as well as a link to the survey. But if you have a couple of minutes to do it now, we would be very grateful. And just to remind folks that this is part of our webinar series running through August. There are a lot of other exciting topics coming up that we really hope you'll join us for. Join us in a couple of months. We'll be talking more, as I mentioned, on our adolescent and our teen series that we'll be doing, and also highlighting some of the work in SBIRT around LGBTQ populations and military. So please take advantage of those and sign up. And I want to thank everyone again for joining us and thanking our sponsors and our partners who have come together to make this education available, SAMHSA, NORC, the National SBIRT, ATTC, NADAC, and the BIG Initiative. So thank you, Eric, for your presentation today. Thank you, Misty, for facilitating. And we hope to meet with all of you again on our next webinar. Thank you.
Thank you.